So guys, let's start with the discussion of the ankylosing spondylitis. It is as common, okay, as around 1.5 million people in the world has this. Okay, so let's start with the case first of all. So this young gentleman is with us, and this young gentleman, 20 to 25 years of age, he will come to us, and on arrival he has a complaint of back pain, as you can see, and there is some eye complaints also in this patient. Okay, so he is coming with a chronic lower back pain, okay, with eye complaints since 4 years. It is associated with the stiffness of the spine or stiffness of the back. Okay, along with that, the stiffness usually lasts for around 1 hour in the morning, and it is aggravated with the rest and getting better or relieving with the activity. Okay, so we know whenever such a phenomenon is there, it is called as inflammatory pain. Okay, so this is typically seen in inflammatory arthritis. So this is inflammatory arthritis. It is chronic arthritis, and it is mainly affecting the spine in this patient, and because of that he is having lower back pain, isn't it, or back pain in general. Okay, he says that this back pain is so severe that he has to wake up. Okay, he has to wake up from the sleep sometimes because of this pain. When asking about the history, he says that his father also has this history, and his father was actually B27 positive. Okay, HLA B27 positive. Now with this so many clues around us, we actually have the idea that what could be this disease. All right, and that's how the approach for our new Harrison 10-minute Harrison series will be like. Okay, so this guy is basically a case of ankylosing spondylitis. Now let's briefly discuss what is ankylosing spondylitis and what are the features, how to diagnose this patient, and how to treat in less than 10 minutes. So first of all, let's see about how the spine is basically looking in the ankylosing spondylitis patient. So as you can see, normal anatomy of the spine is like this. There is a normal curvature of the spine, that S-shaped spine curvature is there, and in this patient there is a loss of normal curvature of the spine. So it can be linked with three things. First of all, there is a reduced joint space. All right, so I'll write it over here. Yeah, so it can be linked with three things. First of all, there is reduced joint space, there is bony ankylosis, okay, and there is some sort of inflammation going on. Okay, so for that, let's see what is the pathophysiology. So when we discuss about the pathophysiology of this disease, so we have four important things. Okay, so first is obviously HLA-B27 status. Whenever you are HLA-B27 positive, so that actually triggers an immune dysregulation. Okay, so it's gonna trigger what? Immune dysregulation. So what does that mean? That means your autoantibodies will be produced against your body cells or your joint cells, and that will disrupt the joint, causing joint erosion. Okay, so along with that, ERAP, HLA-B27 1 and 2, and ERAP 1 and 2 and HLA-B27 will be positive. Second factor is gut dysbiosis. Okay, so this gut dysbiosis basically is affecting your intestines. Okay, intestinal favorable guts, basically, or favorable bacteria for the digestion. Okay, so this gut dysbiosis also has a role in ankylosing spondylitis. Then stress, mechanical stress, or structural abnormalities of the enthesis. So what is enthesis? Enthesis is the connection point of the ligaments or tendons to the bone. Suppose this is a bone, so this becomes enthesis, just like your Achilles tendon. So that end point where it connects to the bone, that is called enthesis, and that's why you can have the heel pain in these patients. And the fourth factor for the pathophysiology is environmental factor. Now, all of this will cause immune dysregulation, altered immune response. Eventually, they will lead to the activation of the interleukin 17, interleukin 32, then cytokines basically, and TNF alpha. Okay, so this TNF alpha, along with interleukin 17 and 32, has a major role of the inflammation in this patient. Okay, so eventually there is an inflammation, and that goes like, first of all, you have enthesitis. Okay, enthesitis is nothing but the inflammation of this enthesis, which will Eventually, inflammation continue, bony erosion will occur. Then new bone formation will be in the form of osteosclerosis, okay, or osteogenesis. New bone formation will be there, and that will lead to the ankylosis, okay, and fusion of the joints, okay. So this fusion of the joints is one of the reason why you will see X-ray showing typical appearance of the bamboo spine in this patient, which we will discuss. But remember, not only the bones, but you have certain extra articular feature in these patients. So what are extra articular? That means apart from the bone, you have anterior uveitis in this patient, in which your iris and ciliary muscles are affected. Iridocyclitis, basically anterior uveitis is caused. Then you will have restrictive lung disease. Why? Because there is an involvement. Okay, so if this is the vertebra and these are the ribs, this is called as costovertebral angle. So this costovertebral angle will also get fused, causing restriction of the lung. Okay, so we'll have interstitial or restrictive lung disease in this patient because there will be no chest expansion. So on examination, you will see there is a bony erosion, or on examination, you will see there is a stiffness of the spine, and there is a positive Schauber's test. So what is Schauber's test? So Schauber's test means when you ask patient to bend the spine, okay. So if you, basically this is the person standing and you place two marks over here. So let's say it's a 10 centimeter. So normally whenever you are bending your spine, the distance should be increasing by more than 5 centimeter. If it is not increasing by 5 centimeter, it is less than 4 centimeter, then you say this is a positive Schauber's test, and that is one of the feature, not diagnostic, but that is one of the feature or the clinical sign basically for the angstpon. Okay. Now also there will be chest expansion which is reduced in this patient. Chest expansion less than 2 centimeter will occur. Now coming to the X-ray and MRI features in this patient. So make sure you do MRI first, then the X-ray. Why? Because MRI features are quite early detected. Okay, you will have edema, marrow edema basically. Marrow edema will be seen. Okay, at the sacroiliac joint earlier, even a year earlier, and in X-ray also you can see pseudo widening. Okay, of sacroiliac joint. Okay, so these are typical features for the ankylosing spondylitis which you can see. Along with that, you will have this bamboo spine appearance, or there is a squaring of the vertebrae. Okay, so vertebrae. So this is one of the this is one of the normal, but if it is not happening, then it is called as Schauber's test positive. So let's see those images. So as you can see, there is a squaring of the vertebrae over here. This red square is there. Along with that, this kind of bamboo spine is appearing over here. There are some syndesmophytes because of the ankylosis, bony ankylosis. You can see the syndesmophytes, and this type of lesions can also be seen. So at the just in between the vertebrae we have Anderson's, and at the end along the lamina we have Romanus lesion. So these are the feature of the ankylosing spondylitis. Now how do we diagnose this patient? So diagnosis is by ankylosing spondylitis, axial spondyloarthropathies. Okay, ASAS criteria is used for the diagnosis. So in which we have two arms. One is imaging and one is clinical arm. Okay, so in imaging arm, along with MRI or X-ray of sacroiliac joint, suggesting the patient has sacroiliitis. Okay, so sacroiliitis should be there, plus more than one. Okay, remember, more than one features. Okay, more than one features of angstpon should be there. What are the features of angstpon? We will discuss that. And in clinical arm, your HLA-B27 should be positive. Okay, this HLA-B27 is positive, plus you should have more than two features of angstpons. How many? More than two features. Now what are the features of the angstpon? So here we go. We have inflammatory back pain, which we have seen. Arthritis, yes. Enthesitis, yes. Anterior uveitis, yes. Dactylitis, peripheral ankylosing spondylitis in the form of dactylitis, you can see. It can be associated with psoriasis, Crohn's disease, ulcerative colitis, It should be associated with a good response to the NSAIDs and family history of angstpon, HLA-B27 positive and elevated CRP. So these are the other features of angstpon which should be positive. Okay, so but make sure in clinical arm more than two clinical features, and in case of imaging arm only one feature is also sufficient. Now coming to the treatment of these patients. So treatment, we have three main options in this patient. Okay, so treatment, three things we have. First is lifestyle. So lifestyle is very important, and the I would say it is the most important way of treatment in this patient because there is no definitive treatment. Okay, so you ask the patient to do exercise, mobility exercise in the form of swimming. Okay, in the form of swimming, yoga they can do. They should do mental exercise in the form of meditation, because we have seen mechanical, even social stress can also lead to this. Okay, ask the patient to work out as well in this patient. Okay, to reduce the joint involvement, and patient will feel much better after exercises. There are so many studies. Even Lancet has published a study according to that. Now coming to the pharmacological measures. So this was non-pharmacological, then pharmacological, and then we have surgical measures. Okay, so what are the pharmacological measures? So pharmacological measures are divided into the two. So for mild disease we have, mild to moderate disease we have NSAIDs. Okay, and for moderate to severe diseases we have biologicals. Okay, so biologicals in the form of two. That is what causes this disease. The first one is interleukin 17 inhibitor. So what is that? The answer is secukinumab. Okay, secukinumab. Okay, secukinumab. And we talk about the TNF alpha inhibitor, that is etanercept. Okay, so this plays very important role in the moderate to severe disease. Make sure you don't give systemic steroids in this patient. No role basically of systemic steroids in this patient, but you can give articular steroids. Okay, so intra articular steroids can be given in this patient. Finally, surgical, you can do total hip replacement in this patient, or you can do osteotomy basically. Okay, osteotomy, that means you are breaking the bone. Okay, we are breaking the vertebral. Okay, that is called as vertebral osteotomy. If it is done only if the kyphosis is there. Okay, so in these cases you can do this. So this is in general how is the ankylosing spondylitis is, and we have thoroughly discussed this within 10 minutes. I hope you like this lecture. Please subscribe to this YouTube channel, and if you are interested in the full Harrison based medicine series, please WhatsApp on 7588354545, and please comment that what are the other things that you think can be given in these patients of treatment of ankylosing spondylitis, and please share this video with your friends. Thank you.